The first discussions and presentations are coming from two very good friends of mine, looking at the future, emerging opportunities of private health sector. I think that this conference would not be a conference if we didn't look ahead, given the rapid rate of change in everything that we are doing. And probably some of the things that they're looking ahead on, some of you will find that you are already doing them. So it may be looking behind too. But to lead us through these discussions are two great friends of mine and colleagues of mine in the World Bank Group. Ian Clayton-Jones is a principal health specialist in IFC and a member, which is a member of the World Bank Group, but he's also part of the team that has organized this very, very good conference here. He has his background in health and economics with MBA and the medical degrees that one gets. And he also has very, very strong linkage and background in his past from South Africa. So he has his roots in the continent. Next to him is Jorge Coarasa. For those of you who don't speak any Spanish, that is George. And Jorge is a senior economist with the World Bank, now based in New Delhi. Prior to that, he'd worked in Mexico in the Ministry of Health. Prior to that, he had gone to very many schools, including the very famous ones. And prior to that, he had been part of our team of Health in Africa initiative, working out of Nairobi on harnessing the private sector participation in health. These two gentlemen are going to guide us through the discussion on looking ahead. They all have crystal balls, and they also have lenses to see further than us. So I do not know who will start, but Ian, will you?
Yep.
Thank you.
Thank you very much, Karma. This morning, Karma spoke a little bit about them and us. And we strongly believe in the bank group that the public and private sectors are going to work together more and more in the future in order to actually deliver what has to be delivered in healthcare. There are a number of countries we work with already who I think are further ahead than others in this, and it's definitely a trend that we see is happening. But in the bank group, we're making an effort to lead by example. So actually, Jorge is indeed a senior economist at the bank, but until very recently, he had most of his career with the bank group actually in IFC. So he was with us, and he's now with them. And I was joking with him earlier, you can tell because us wear a tie and them do not. So anyway, now the title of the session is Looking to the Future, and as Karma was explaining, there are going to be two parts. The first part is going to be Jorge and myself, and then we have somebody whom you'll meet in a little under an hour called Malcolm Frank, who's going to take you also on a sort of vision of certain aspects of the future. Now, that's a really big title. I mean, healthcare is big. The future, who knows? So we sat and we thought, okay, we have roughly an hour with you. We want to keep this as interesting as possible. How do we do that? So we're going to do a few things. The one is that the first part is going to be a little presentation. We are not going to do death by PowerPoint, just a little gentle PowerPoint. And we're actually going to involve you. There's going to be some participation as we go through the PowerPoint, so that you're still awake and thinking by the time we get to the end of the PowerPoint. And most of the time, more than half, is actually going to be a general discussion, which we would like to facilitate, but we'd love to hear thoughts and questions from yourselves. So in order for you to participate, you would have found on your chairs there are these funny little remote control looking things. And they're actually, I'm sure many of you have seen them in functions before. These are voting devices. So we're going to ask your opinion and your thoughts on a few questions as we go through this. And I'll show you, exactly which buttons you need to press when we come to those. I've been asked to make a special announcement. that we've laid out these nice devices. You got those lovely conference bags, and they should not have a relationship, right? They're not going to work for the TV at home. And please don't absent-mindedly slip them in there when you tidy up to leave. Please leave them on the chair or on the floor under the chair, and we'll put them away afterwards. So let's get into our bit of a presentation. And again, there are so many different things we can look at going into the future. So we picked just a couple of items to touch upon that we thought would be particularly thought-provoking, perhaps things that people don't frequently think of when you think about the future of emerging markets healthcare. We all know, I mean, most of us are experiencing growth. In many instances, the economies of our countries are growing, not every single one, but many of them are growing. We are generally dealing with larger populations, and by and large, the world is gradually getting a little bit older in each country. So you add all of these things together, lifestyle changes, some industrialization happening, depends where your country is on that path. But generally, we're experiencing rising demand. That really isn't news. So we thought these are the things that are often spoken about. So we'll go for a few things that are perhaps a little more unusual or below the surface, or things that we see as perhaps just very early trends. So we had a little session before this on non-communicable diseases and what's happening in emerging markets. I'm going to take you through, first of all, you know, if we look at the top left there, I think most of us know heart disease is a leading cause of death in most developed countries. If you look on the right there, it's now becoming a major cause in many upper middle income countries also. Now, we in the World Bank Group are used to this upper middle income, upper income, blah-de-blah. Now, what does all that mean? It's pretty much defined. There are some other aspects, but the easiest definition is to look at the average per capita income every year. In developed countries, it's typically more than about $12,500 a year. For a rough number, about $1,000 a month. There are very rich countries in that category, and there are some countries that are only just into that category. We're in one that's somewhere in the middle. Czech Republic is somewhere in the middle of that. If you get into upper middle income countries, those are generally countries with incomes around $4,500, let's call it $5 for an easy number, to $12,000 a year. Those are roughly the numbers. So, you know, not super prosperous, but you can do quite a lot. But what happens when you start getting into the low and lower middle income countries? And what are we talking about there? Well, a low income country is less than about $1,100 a year per person. That's under $100 a month. I don't think any of us in this room would find it too easy to get by on $100 a month. It's really tough, okay? And then low middle income countries are in that little bit in between. They're somewhere between $1,100 and about $2,500 a year. So roughly between $100 and $200 a month. So everything we're going to talk about here is countries where people make less than $200 a month. 26 of the 34 countries in the world that fall in the low income category, people are under $100 a month, happen to be in Africa. So we're going to talk a little bit about Africa, about some interesting things that are beginning to come out of Africa. And the first thing that people usually think about, and I mean, I kind of grew up as a doctor, as it were, in Africa, and I saw a lot of infectious disease. And, you know, I didn't see a lot of non-communicable diseases. However, I'm starting to get a little older now, so maybe, you know, the number of years is adding up, and, you know, things are beginning to change a little. But historically, doctors working in Africa encountered very few patients who had heart attacks. So when they saw heart disease, it was sometimes stuff related to hypertension, but they really didn't see ischemic heart disease like we know in the West. And they concluded that Africans, and I was taught this in medical school, are genetically less susceptible to ischemic heart disease because that's what we observed. And it's a Western problem. So I want to get your opinion on the line of reasoning here. If Africans have few heart attacks, logically, they must have low risk factors for heart disease, right? For ischemic heart disease, like we know in developed countries. So this is where, for the first time, you're going to pick up your little voting remote controls. And this one's really easy because there are a whole bunch of buttons on there, but you only have to worry, I think they're at the top left. There's an A. Okay, yeah. There's an A button and a B button. So if you think that that statement is true, you select the A button. And if you think that statement is false, please press the B button. So I'm going to give you a few seconds to think about it and, you know, I won't say voice your opinion, but, you know, make your opinion felt electronically. And we move to the I'm just going to ask my technical folks in the back there. There was a beautiful slide when we ran the dry run that came up with the voting results. And are we having any technical issue with that? It always works perfectly when you do the rehearsal, you know. Okay, we're just going to check quickly what's happening there. Because it really is interesting to see what people's thinking is on these things. Can we have a quick news report from there, folks? Is it fixable, or should I just move on to the next slide? Okay. I think I'm just going to move along to the next slide and give them a chance to try and sort that out for the next. Okay, if I can move along to the next slide. So, yeah, guys, I think you've disabled. I'm not able to move to the next slide. Could you just permit that so that we can do that?
Tell a joke or sing.
Huh? Oh, okay. Did you hear the one about the guy who wanted to do a presentation about the future of healthcare? Yeah. We're getting that emerging market feeling here. Okay. So, well, it would have been fun with the voting results to see what people think. But essentially, we had some very counterintuitive data that began to come out of the first serious study that was actually done on this, which was done very, very recently. Because for the longest time, it was really observation. I mean, people were just, you know, observing what they found in medical practice in Africa, and the conclusion was made on observation, but it wasn't, you know, that scientific because it wasn't really a mass screening of the population saying, are the risk factors for ischemic heart disease actually there or not? So recently a study was done, started a couple of years ago, and the results were published in 2014, of 4,300 adults in 10 countries in Africa and the Middle East. I'm going to focus on the ones in Africa because the Middle Eastern ones were actually generally upper middle or high income countries. But the ones in Africa fall in this category of they're below $200 a month. And they found very high levels of dyslipidemia, which is a major risk factor for ischemic heart disease. Now, you know, a lot of people here are medically, you know, very familiar with medical terminology, but for anyone who's not, it essentially means you've got the wrong kind of fats in your bloodstream. It means wrong in the sense that they increase your risk for ischemic heart disease. Now, we never expected to find that in Africa. I mean, I was taught in medical school that, you know, that's a problem that we've seen in certain populations. It's genetic, but it's actually, you know, not something, it's very rare in Africa. Folks, are we having, yeah, thanks. So the results were very surprising. These are the 6 African countries that were sampled. The AFME is simply the average. It's the average for Africa and the Middle East. But the interesting part is there were no other African countries in the sample. They happened to pick these 6. Every single one of the countries they picked turned out to have higher rates of dyslipidemia in the population than in the United States. Now, why do I use the United States? Well, first of all, there's a lot of data about the United States. And secondly, it causes, heart disease causes 1/4 of all deaths in the US. So 1/4 of all people who die of heart disease. It is the leading cause of death there. And yet here you have populations who are at higher risk than this population here. So we began to, and in fact I became aware of this from a conversation with a professor of cardiology in Senegal, who said he became interested in this about 4 years ago. He'd been brought up with the same belief as me, that genetically people in Africa just have a lot less risk for this. And suddenly his cardiology service, which had been looking after people with problems from maybe hypertension or certain other cardiac problems, maybe some of the infectious cardiac problems like rheumatic heart disease and so on. He said suddenly they were being increasingly stretched because they were having to deal with more people with heart attacks, and they're not very well trained for it because it's rare. So here we have this finding that completely goes against the conventional medical wisdom. They actually looked at a number of other risk factors in the study. I'm not going to take you through all of them. But the next one we looked at, that they looked at, which is a second sort of really big risk factor, is high blood pressure. And what did they find? Well, again, very... Oh, okay, it's changing on here, but not... Okay. So again, we found that the blood pressure in the population in 4 of the 6 African countries sampled, the rate of high blood pressure in the population is higher than in the US. And the 2 that are lower are not lower by very much. Now, the important thing is we're not talking about are you treated or not. This is, do you have high blood pressure, whether you're on treatment or not. So a lot of people in the US are on treatment, although in fact the rate of untreated high blood pressure in the US is still quite high. In many of the insurance companies' surveys, it runs as high as 50% of people who have it. But the point is, this is another very important risk factor, and it's actually present at a higher rate in these populations. So, again, just to remind you that in the US, where this is present at a lower, this risk factor is present at a lower rate, 1/4 of people who die of heart disease. So what has been going on in Africa? Well, people didn't live as long as people in the US in the past. And there wasn't a lot of change about this. If you look at the last decade of the previous century, it was basically flat. Life expectancy was about 50 across the entire African continent, north, south, central, east, and west. Now, by 2012, just 12 years into the new century, it's risen 16% to 58 years. There have been a lot of advances, actually. I mean, infant mortality has been coming down. There's been, all sorts of campaigns that have been reducing deaths from malaria. There have been all sorts of additive factors coming together. The HIV epidemic is coming better under control. There are a lot of factors that are adding into this. But the result is now the gap is closing. I mean, the average for the world is about 70. The average in high-income countries is about 80. The gap is still there, but, the gap is now just a bit over 20 years, not 30 years. Now, this is expectancy. It doesn't mean the population has aged yet to that degree, but it is beginning to age. And as it ages, what are we going to be dealing with? Because suddenly we're finding, this literally was not known 5 years ago, that there are risk factors that we know cause a problem in developed countries that are present at higher rates in these populations that we thought were not vulnerable to this disease. So lifespans are increasing, and we think it's possible that as people live longer, stuff will be unmasked that was basically hidden by the fact that lifespans were shorter and people were dying in the past more of infectious disease. As that is coming under control, infectious disease is coming under control, it's possible that parts of the world that seemed to be at low risk might actually be at higher risk. Now, the question that poses is, are African health systems prepared for the rise of non-communicable diseases? And for that, I turn to my colleague.
So, of course, this question is impossible to answer. Nobody has the data. But we have some data that give us some direction, some pointers. And we're going to give another chance to the technology. And so I'm going to ask you, what is the probability that if you walk into a clinic in Nairobi, Kenya, with the symptoms of unstable angina, you are correctly diagnosed and prescribed the correct treatment for that. And, whoop. Last chance for the technology. And as I say this, bear in mind that Kenya has one of the most sophisticated health systems in the region, that Nairobi is a hub for healthcare. People all over East Africa and beyond go there for care. Are we good? Can we open the voting? So you need to choose A if you think most people who show up with the symptoms are correctly diagnosed and prescribed the right treatment. So 3 out of 4. You need to choose B if you think is half and half. C if you think only 1 out of 10 people will be correctly diagnosed and prescribed the right treatment. D if you think it's less than 1, so 5%. And E if you think no one is correctly diagnosed and prescribed the right treatment. So let's see if we can open the voting now. Okay. So most of you, 42%, thought the right answer was 50-50, I think. 10% is the right answer. No, I know 10% is the right answer. I actually asked you the question because I know the answer. But 42% of you, so 9% of you thought most people get correctly diagnosed and prescribed the right treatment. 42% of you thought it was 50-50. 35% of you got it right, it's 10%. 5% of you were overly pessimistic and thought it was 5%. And 2% of you are very, very pessimistic and thought it was 0. So where does this data come from? These data come from some cutting-edge research called Standardized Patients. There's actually has its origins in medical education in the US. Then a colleague of ours at the bank and a group of researchers took it to India and started using it there to measure the quality of care in outpatient settings for non-invasive procedures. Then it was replicated in China, and then with, thanks to the leadership of Kama and Njeri and Bernard, who are in the audience, and the Health in Africa team, we brought this research to sub-Saharan Africa for the first time. And so these data come from testing whether this research can be done in sub-Saharan Africa. And so Nairobi was the pilot. And the research worked. And now the next is we're going to test it in 1,000 clinics in 3 counties in Kenya. But what's becoming interesting about this research is now we have this for India, China, and Kenya, and we have it for, I showed you stable angina, but we also have it for other diseases. And what's really interesting, and the reason we were surprised by this result, is that if you look at other diseases, Kenyan doctors, and when I say doctors, it includes doctors, nurses, clinical officers, are actually quite competent. They are, for a lot of, when we present this data in Kenya, people are surprised that Kenyan doctors are actually better than Indian doctors in diagnosing and prescribing the right treatment for diarrhea, tuberculosis, asthma. They're far better than Chinese doctors. If you show up with symptoms of diarrhea in a kid, you're 400 times more likely to get the right diagnosis and treatment in Kenya than in India. And this surprises many people in Kenya because they think of India as the Apollos and the Fortis and the Maxes of the world, but those are just the sort of the tip of the iceberg of healthcare in India. And so I won't get much into this, but what would be good in the discussion is we have a lot of Kenyan doctors actually in the audience. If we can advance some explanation as to why do we see this disparity where for some diseases you have the best among the 3 countries we're comparing, but for unstable angina, only 1 in 10 people will get diagnosed. And this is Nairobi, right? This is probably the most sophisticated healthcare providers in the rest of the country. And so the other thing this is telling us is, if you believe Johan and you believe Jean-Pierre and the people who were here in the panel for NCDs, NCDs will eventually, not tomorrow, not next year, but it will eventually become a big problem. And so Thomas Bolicki talked about crisis. I would look at this data and I think explosion. So heart disease is going to explode eventually. If you combine the previous session with this, some of the risk factors that are also important for heart disease are small in Africa right now, like obesity and others. So these are factors that tend to get worse with higher income and lifestyle changes. So there could be a tipping point where the existing high-risk factors that Johan showed you and others that are currently low, combined with people living longer, things like heart disease are going to explode. And the truth is, health systems in Africa and other low-income countries, and even low and middle-income countries, are not prepared for this. And that is in part because governments, donors, and others are still very much focused, for many good reasons, on infectious diseases and communicable diseases. And as governments most of the time do, they're probably only going to get seriously involved in these when this explodes. And so the reason we're bringing these two things together is to say there is a crisis of non-communicable diseases looming. Systems are not ready, and this potentially could be a big opportunity for the private sector to step in, bridge this gap, build the capacity for health systems to address this. Now, the next question, and we're going to switch gears a little bit from mostly clinical stuff to more management stuff, but the question is, will it be automatic that the private sector takes advantage of this opportunity? Will you just continue building hospitals and creating providers and so on, and will this opportunity fall on your lap? So Johan is going to try to answer that question.
So what we're going to talk about now, you'll see will link up with a little bit with what we've been talking about, with the having to be ready for non-communicable diseases, for future demands on your businesses that are maybe going to be different or increased from what they are today. And what I'm going to do is take you through some data here and a bit of a, again, one of these exercises where I'm going to want your opinion, because it's, the intent of this is to help introduce a concept that we think it's relatively early stage, although it's becoming quite mainstream in developed markets. We think it is something worth knowing about, probably for anyone running a business in healthcare, whether you're in a developed or an emerging market. And we think it's something that is going to, the word revolutionize is overused, but I think this is going to have a profound impact on how we manage healthcare businesses going into the future. So here's our little exercise. We've got a made-up clinic, although the concept is based on something that really happened in a real clinic, and I'll tell you about it. So Fantasia Clinic, because it's all made up, has the following departments with the following EBITDA margins. And you can see there, that most of them are hovering around somewhere 16 to 21%. They're all chugging along reasonably well. But then they've got this outlier. They've got the physical therapy department that's sitting there with just a 2% EBITDA margin. So you can imagine by the time you've got, some depreciation and you've paid some interest and so forth, it's not actually a profitable department. It's really borderline. So imagine now that you're the CEO of this clinic. You've got this information in front of you, and you've got to make a strategic decision. Now, one of the things I should also mention is this department actually, this physical therapy department actually uses quite a lot of floor area in your clinic, because they've got like a gym and a rehab area and all this kind of stuff. And you're starting to think, these people don't make that much money. I've got some other things that make more. Do I really need to keep this? Well, they work with the surgeons. I don't know. What do I need to do with this? I'll tell you a bit about the country later, but the principle would apply anywhere. So essentially, I'm asking you to think, try and make a rational decision. I know I've got limited information here, but with what I've given you, if you were the boss, would you choose to close the department and do something else with that space, or would you choose to keep the physical therapy department? So it's the same thing with the clickers. If you think you would keep the department, you vote yes with the A button. If you think you would close the department, I'm sorry, if you think you would not close the department but keep the department, vote no with the B button. And hopefully this time around our technology works. Oh, please, oh, please. How's it doing back there? There we go. We've got voting. And you're probably figuring by now we're giving a lot of counterintuitive information here. So a lot of people have voted no. They would not close the physiotherapy department. When we get in the discussion period, actually, I'll be curious to ask a few people what their thinking is behind that. Maybe they're thinking it's integrated with other care and so on. But the correct answer is no, don't close it. But the reason is maybe not what you're thinking. It's not because it's integrated with the other departments. It's because you actually don't have the right information. Instead of basically what this hospital was doing, and this is not unusual. I'll answer your question now. Maureen, you asked me what country is it in. By and large, this is made up, but it's based on a case study that really happened. That's actually been turned into a Harvard case study. It happened in a fairly sophisticated clinic in Germany. So this is not some place where people had lousy accounting systems. I mean, I don't know. They probably had, SAP. It's German software. I mean, they had. The point is, it was a sophisticated place, and they had what was considered pretty good accounting, right? But they were allocating their costs, and this, we allocate costs in quite irrational ways in healthcare services. They were allocating it according to floor area. So they knew what their revenues were. They knew what their total costs were. And then those costs were allocated in the different departments according to the floor area that they occupied. And this is not that unusual. Now, physiotherapy uses actually quite a big floor area. But the fees for each thing that you do are quite a lot lower than in surgery or imaging or one of these other departments. Just before they were actually planning to close the physiotherapy department, by the way. The board had met and they'd said, look, this thing's not making money. Let's just cut it and do something better with that space. And people can go and get their physio somewhere else. And somebody thought, maybe we should just get a better analysis of the costs here. And they got some consulting done for them that used time-driven, activity-based costing. And once they had the right information, they discovered it was, in fact, the most profitable department in their hospital. And so they had been about to make an irrational business decision because they had bad information. So they were going to close something. This was the most profitable department. Now, the reason it turned out to be quite profitable is because, yes, the fee that you charge for each thing that you do there is not that high. But, physiotherapists also don't cost what surgeons cost. So, the cost of delivering that service also wasn't that high. So it turned out the margin was actually pretty good. And the floor area really had nothing to do with it. That was really just a very arbitrary way of trying to allocate cost. The other way a lot of hospitals and clinics end up doing it is they look at the total revenues that a particular department generates or a particular procedure, and they just allocate the same percentage of costs underneath that. Direct costs like consumables are usually well known, but things like time that staff spend working in that delivering that particular piece of care is usually very poorly understood, and this is almost universal. The most sophisticated places in the US and Western Europe and that are about as at sea with this as people working in many emerging markets. So it really doesn't seem to help if you're in a developed country because nobody thought about this until the last few years. So what time-driven activity-based costing does is to use you figure out a process map of the steps that you take in delivering that piece of care and how much time each healthcare personnel and non-healthcare personnel, all people involved in delivering that care, how much time they spend with the patient on each of those steps. And then there's some detailed but simple math. I mean, it requires a lot of data, but it's high school mathematics that actually figures out how much the time of each of those people is worth. And it incorporates not only what you pay them, but also maybe the space they occupy to do their work, which you have to pay for, the computer they use, which you have to pay for. I mean, you get the picture, the other ancillary items. And you can come down to a cost per minute for every doctor, every nurse that works, delivering care to that patient. And then you start to make much more rational decisions, not only understanding what the cost of a package of care is, but also to understand, gosh, and these are about roughly the real numbers in the United States. A doctor costs you about $6 a minute, but the physician's assistant costs you about $1.60, and the registered nurse about $1.20, and the clerical staff get down to about $1 or sometimes lower than that. So you don't want somebody doing a job at $6 a minute that could be, if that job could be given to someone who costs you under $1 a minute. So you start allocating the tasks more rationally as well. But this is also just one part of a bigger concept, and the concept is value-based healthcare. And some of you in the room have probably begun to come across this, but it's still a relatively new concept. It's really come out in the past decade, and it's come from a lot of, the foundation of the work came out of Harvard. And it actually, the initial thinking on this has really been driven by Michael Porter, who's fairly well known, but a lot of people don't know that in the past decade, most of his research work has now focused on healthcare. I went to business school 16 years ago. He was the competitive strategy guy. He was the guru in the world about this. But in fact, he has switched a lot of his work to healthcare, and he did that because the first time he encountered this industry, he said he'd never found an industry where there was such a big gap between what's happening now and what is possible. And, naturally that draws you in. I mean, if you're a researcher and you're a consultant and stuff, I mean, there's just so much to be done. So value-based healthcare is about figuring out the health outcomes that matter to patients, not to the doctors and the nurses, but to the patients, dividing that by the true costs of delivering those outcomes, which you determine with time-driven, activity-based costing. And from that, you start to make rational decisions as a purchaser of care. And you're able to compete rationally because you can say, we deliver, a cure for this type of cancer for this amount of money. And people go on to have a productive life for another 20 years. That's what we can say as this cancer center. You put that out there, and this is what some leading centers are beginning to do, and they're starting to actually publish their results on the internet. Your patients can make rational decisions in choosing care, but your payers, who are often more informed, can make rational decisions. The insurance companies, the public insurance. Although we can have during the discussion period, I can tell you they found some interesting dynamics with the insurance companies in the US as this has begun to come into being. And I'm going to hand to Jorge for some concluding thoughts, and we're going to actually take it straight into an open discussion from there.
So basically, probably under-delivered on the title of the session, which was all emerging opportunities for the private healthcare sector. But so just to wrap up, just a few major ideas. One is non-communicable diseases are on the rise, even in low-income countries. These potentially could present an opportunity for the private sector because these systems are not by far ready to deal with this looming crisis. This is not yet the focus of the public sector. Now, we didn't talk about this, but if you tie this up with what was discussed in other sessions about the emergence and the much higher prevalence of forms of public money being used to purchase privately delivered care, whether it's contracting, PPPs, insurance, you name it, this means that this drive for universal health care, universal health coverage, which will include expanding these mechanisms, could significantly expand the market for private healthcare providers. But this is not going to be automatic. This will require healthcare providers basically changing their approach to how they manage their business. And this would include two things. One, knowing their true costs. And in this sense, Dr. Sherry, the keynote speaker yesterday, he's a trailblazer, right? His doctors are getting profit and loss reports by SMS in his phones. That's what it's going to take, right? And so the winners and the people, the businesses who are able to capitalize on this opportunity are going to be those companies that figure out their costs, lower them down, and are able to offer competitive prices to whether it's public insurance schemes or PPPs or contracting, because the future, for the most part, is going to be publicly financed, privately delivered care in a much bigger scale than we see now. I mean, publicly provided care is not going to go anywhere, but if I had to make a bet right now what we're going to see in 10 or 20 years, and this is in line with what other speakers have said, is you're going to see a lot more public money going to purchase care from the provider that's best able to provide it, whether it's public or private. And as we're seeing the public sector very ill-prepared for dealing with non-communicable diseases, if the private sector gets first-mover advantage, most likely the best able provider will be a private provider. But reimbursements, rates, and prices are not going to be whatever you want to charge. They're going to be, the public sector is going to try to maximize that public dollar or public, whatever it is, rupee, and make it go as fast. So really, those who get early on these tendencies of value-based care and time-driven, activity-based costing and so on are going to have a potentially massive competitive advantage in this new scenario. So that's it for us.
The session was a little late in starting, as the previous session ended a little late, and the coffee break was fairly generous. So we will keep some discipline here and make up a little bit of time into the next session. But I think we have a good 15 to 20 minutes still. So we'd love to invite a few questions from the audience. So I see we have one person at each microphone already. So you know what, I'm going to start with Eric and then go to Victor.
Okay, thank you very much. I'm Eric de Rodenbeck. I'm the CEO of the International Hospital Federation. So I thank you for the presentation and this very provocative statement about cost accounting. I guess you have been provocative there because in healthcare facilities, we all know that between 55% and 80% of expenses of operating costs are on human resources, and therefore we do cost accounting related to human resources most places. But what you highlight is that cost accounting is not well implemented in the details. And you are very right in showing that this is, and it can get very complicated when you want to do value-based purchasing, because you have a lot of interaction between the elements of practices in the cost accounting. The point I wanted to make here is it was the fact that we certainly in the healthcare organizations have a lot of progresses to do in managing, and here there is a whole lot of efforts, and the private sector is well placed for that, to improve the management. And where we have to improve the management is changing the paradigm. Let's not forget that a hospital is a production process organization. And the management of production process is something that is poorly managed and not managed, poorly known and handled by healthcare facilities. So in our organization, we are really pushing strongly so that we look closely. Hospitals, healthcare facilities are production units where you can look how you can optimize the production process. We talked about lean management. That's one of the dimensions that was mentioned on the first keynote speaker. But there is a whole lot of saving and optimization in this area. And this is not the culture that's coming from medical studies, the production process optimization.
Okay, thank you. And just a reminder, I know who many of the folks are asking questions, but just to mention to the audience your name and your organization.
Okay, and Victor Castillo from Colombia. I'm very happy to listen you talking about cost. Cost is one of the biggest issue in the hospital administration. You talk about the value, the add value in the cost for the patient. I would like to know how to manage, how to look that cost in the hospital, how to run and how to check this add value in the cost in the hospital.
Okay. Thank you. That's a great question. I tell you what, let's take one more question, and then we'll answer the two questions. So.
I'm Patricia Williams with Global Health Services Network in the United States, but I'm originally from Argentina. I don't know if there's anybody else from Argentina here, but my question was related to, I wanted to ask if you could speak to the problems that you foresee taking place as a result of the trends in non-communicable diseases in low and lower middle income countries, and what the implications of those are on the private sector.
Okay, thank you. So I'll take the first one, give you the second one. Okay, so I'm going to talk first a bit to the question from Victor Castillo, and then hand to Jorge to talk a bit about the question from Patty Williams. So I think the core thing is understanding a bit about what the, I think it's actually going to be easier if you can see me, stand up. A bit about, what are the sort of the core things in this value-based healthcare concept. I mean, as you saw, it's an equation with two parts. It's one divided by the other. So you need to first of all know what the health outcomes are that you actually want to define. Now, the thought leadership in this has spread a bit. It started at Harvard. It's actually now begun to rope in some other institutions, partly academic and partly commercial. So four institutions got together. You've got Harvard and Dartmouth, who came up with the original thinking under Professors Porter and Teisberg. And then they've linked up with the Karolinska Institute in Sweden and the Boston Consulting Group. So that's where the commercial bit comes in. And they've actually gone and established something called the International Council on Healthcare Outcomes Measurement, which is a non-profit. And they work, those are the sort of main organizations that set it up, but they work actually with now a growing number of hospitals and clinics and some other health service providers, but a lot of it's hospitals, predominantly in developed countries at this point. And basically they're assembling data, and what they've begun to do is define what are these health outcomes that we should be looking at. Because the concept is they should be outcomes that matter to patients. Now, what does that mean? It means that if you, for example, needed a joint replacement, a doctor may define a good outcome as the joint is fully functional, there is no infection or complication, and healing was complete 6 months after the operation. The patient may define it as, I can actually walk again without pain, I can sleep through the night without waking up multiple times with pain, which prevented me being fully awake at work, or I can dance again with my partner, which I couldn't do for many years because of pain. So there are different ways that these things get looked at by the patient versus the doctor. So they have, so that everybody doesn't have to reinvent the wheel and have stuff that cannot be compared, they have actually begun to develop a database of standardized health outcomes that are of value to the patient. And they began this work in 2012, so it's actually making some decent progress. And they have covered about 45% of the global burden of disease. Naturally, a small number of conditions accounts for a large proportion of the percentage. So initially you make quite fast progress, and then it's going to take a little longer. But each year they are adding to that, and this year they're hoping to take it probably to 60% or so. So that's actually available on the internet, free of charge. The website is the W's and then ICHOM.org. And that stands for the International Council on Healthcare Outcomes Measurement. So you don't have to reinvent the stuff. It's already being made available free of charge. So that's the top part of the equation. What are the outcomes that matter to patients? Then there's the part underneath of trying to figure out the time-dependent activity-based costing. That's a bit more complex. Harvard is actually offering courses on this that are not outrageously expensive. It's a few $1,000s and about 3 days of training. And for healthcare executives, accountants, etc., who want to go and learn how to do this specifically in healthcare. The basic concept of it is actually not that complex. Implementation, the divine is in the details. So you have to actually learn how to go about assembling a lot of the data and the correct way of measuring it. The mathematics is not complex. The spreadsheets are about 3 columns wide. They're just a whole lot of rows. But the concept is not particularly complex. And in fact, what it enables you to do is once you have figured out what the cost is of a particular cycle of care, and that's really what those outcomes measures are going to be about, is complete cycles of care, not just, oh, I had a hip replacement. It's from I started having arthritis to the point where I now can actually fully function again, or I first got diagnosed with cancer through an agreed period of follow-up of care. These are longer care cycles than the way we generally think of care. The idea is you define those and you start to be able to move to bundled packages of cost for these cycles of care, which simplifies also the transacting process between payer and provider. But doing so, bundles of care are not a new concept, but having better information for pricing those is valuable both to the payer and the provider. Let me give you a chance to
I think
talk to
Jon
Patty's question.
answered most of what was raised. And I think we'll have to cut it here. We're not going to take another round of questions. That's the instruction I'm getting from the command. We'll take the 3 questions for the people who are standing. You have to know, Kama was the one who hired me to come into the World Bank Group. So if he says I need to cut it short. So I just wanted to add, throughout the conference, being somewhat of an outsider, I'm an economist, I'm not a doctor, and I work mostly with the public sector. Even when I was in IFC, I worked mostly with the public sector. But I've heard kind of a cry for this group of people to be taken seriously as an industry, as an economic sector. And I think this is the kind of thing you need to do to get there. I joined Deloitte 15 years ago, and we did time-driven activity-based costing and value-based management for auto companies and glass companies. 15 years ago, it was our partners were actually worried that it was kind of going out of fashion because now everybody knew how to do it in-house. And so when I had the first conversation about this panel with Jon, he told me, this is actually a new thing in healthcare. I was completely surprised. So the good news is, and I don't know if there are people from consulting companies, I think there's someone from PwC, but this is also a huge opportunity for consulting companies to develop a practice on these type of tools specifically for healthcare. So I'm not going to add any more to that. So let's go through the 3 last questions.
Shall we start on the right? And don't forget, name and organization, please.
Thank you very much. I'm actually not thinking about the future. Finally, we put Africa on the map today in terms of what I see as the epidemic of the non-communicable diseases. We need to deal with the problem immediately before it completely gets out of hand. But the issue is that of financing. Now, as I see it, IFC and the discussions I've had with some other people will not fund what we call greenfield projects. We've just had an Ebola crisis in Africa, in West Africa in particular, and the World Health Organization was finally criticized for their slow response. Now, are we going to have the same slow response to this epidemic we now have in Africa? Was the IFC, the World Bank, proposing to do immediately to deal with this problem?
Yeah, Kami Arkajabi, USAID. Very quick question. From the perspective of sort of a large payer, be it a government or a private system, how is this different from the kind of cost-effectiveness analysis that, for example, NICE does in the UK?
I'm sorry, the last part of your sentence.
How is this different from the sort of cost-effectiveness analysis that, for example, NICE does in the UK?
Mustafa Hunter from Egypt. Just the last statement that you said that this drift towards the private sector, aren't we killing first the public sector, and aren't we then putting unfair competition of organizations that are burdened with, like the public sector, burdened with lots of factors, and then put them in an unfair competition with a responsive private sector? And aren't these concepts applicable in any organization, irrespective of the ownership? And what's missing in the private sector or public sector, I work a lot on these governance-related issue, is that we don't have an owner that puts this as a return on investment. And finally, would corporatization and putting a mixture of commercial and non-commercial returns on investment foster this in the public sector and create an opportunity for joint ventures and fair competition? Or, as you said, it's the evolution that we just like let the public sector die in peace and we move this gradually to the private sector? Like, and is it a good...
You answer 1 and 3 answers.
Okay. No, you answered the first one. It was about IFC not investing in...
IFC World Bank.
So I'm to be honest, I'm not sure what the question was with the first gentleman. It had to do something with IFC not financing greenfield projects.
Well, and what's the World Bank and IFC going to do about healthcare in Africa right now?
Well,
so
I mean,
some of the health in Africa
my reaction would be first, tackling NCDs doesn't necessarily mean building big hospitals to admit people and have surgeries. I mean, if you came to the previous session, a lot of tackling NCDs is about how do you do the right prevention, and about how do you, the data I presented, it's basic. How do you diagnose and prescribe the right treatment, even in an outpatient clinic? And you see the tendencies are coming from India, even from a telemedicine perspective, even by someone sitting at home and Skyping or FaceTiming or whatever it is with a provider, right? So I'm not sure how this relates to that, but the issue of the financing basically is if countries don't act early on this is a potential financial bomb. And let me give you an example from my own country, Mexico, right? So as probably you know, Mexico has surpassed the US. We're now #1 in finally one thing, and that's obesity and childhood obesity. And we have now a very ambitious public financing scheme called Seguro Popular, which covers 50 million people out of taxes, right? If we realized back, in the early 2000s when Julio Frank was the Minister of Health, if nothing is done, this system that we just have created, and we're getting so much praise from everybody for covering 50 million people, will break our public finances. Because caring for 50 million people who are diabetic and so on, it's just going to be much more expensive than what we're doing now. And so a massive campaign to do preventive care and to have every person who joins Seguro Popular have a screening and know their profile and so on, and massive campaigns to fight obesity. I mean, now it's become not okay to be overweight in Mexico. It's not something that society encourages, and it's been a big change. Now, this hasn't been done by the public sector alone, right? The big change that was brought about with Seguro Popular is that now the government partners with private providers. It's the Mexicans who are here, who I know, at least a couple of them, they would say it's not enough yet. But if you look at what is being done now in terms of the government engaging the private sector to help prevent and fight non-communicable diseases. It's a sea change from what was happening 10 or 15 years ago.
Perhaps I could just add briefly on the first question that I don't know the details of the discussions that you've had that may have given this impression, but we actually do finance greenfield projects. If they have no other capital behind them, that could be an issue. There could be other reasons why a particular greenfield project isn't appropriate, but I have personally worked on them. We do finance greenfield projects. I think you want to... the second question was about what were some of the differences between, the sort of time-driven, activity-based costing and the kind of value for money analyses that have been done by NICE. Folks who are maybe not familiar with the UK, they have a national body called the National Institute of Clinical Excellence, which is, the acronym is NICE, that actually looks at the cost effectiveness of different treatments. Not only that, they actually look at the clinical effectiveness of different treatments, and they issue guidelines to the medical profession and to administrators on things that they found, work very well for care, and also things that are found to be cost effective. Now, I know the principles of it. I don't know the precise methodologies by which they do their cost effectiveness analyses. What I can tell you is the information that the research that they've done at Harvard has brought out is that generally, because private sector places obviously do lots of analyses of what are their costs and stuff, because if you don't, you're going to go out of business if you don't understand how to generate a margin. It turns out, though, that there's an awful lot of estimation involved in this, and an awful lot of irrational allocation of cost that doesn't really reflect truly the cost that occurs. The main problem revolves around people and their time. And as Eric de Rudenbeek brought up, the major cost that we have in delivering healthcare services is people. And we are effectively selling their time to patients along with some sort of cost for the infrastructure that it's delivered in, a whole bunch of drugs and consumables, and a margin on top of that. I mean, that's more or less what we do. So but the biggest single cost component is the people. So if we don't truly understand which of those costs of those people are belonging with particular care that we deliver, and we're estimating it, and we may be allocating it wrongly, you can get the result that was shown in the example in the presentation, where you think you know, but because there's too much inaccurate data in there, you effectively got garbage in, garbage out. So we're going to wrap up there. Okay.
Good.
Thank you very much, Kama.
So join me in saying thank you to Jorge and Dion. The future is out there. You are the future. Thank you very, very much. Yes. Time constraints are with us, but I don't want you to leave. We're going to give you 5 minutes if you have to do something that will make your kidney last longer. But otherwise, we want you to stay right in here. In the next 3 minutes, we're going to start the plenary with the keynote address. So if kidney, yes, nothing else, please stay on. Thank you.